have to keep in mind till the midwifery cadre is not implemented in our country. We the RN and RM, we have to take the responsibility in all aspects for the improvement of maternal and child health, because mothers and neonates, they are the innocent victim by our society. So it is our responsibility to reduce the neonatal mortality and long-term sufferings of the mother and the neonates, and also to reduce the maternal mortality, because they are all victims of this society. So with this short introduction, this session will enrich you with some points regarding the education, training, role and responsibilities, and some legal and ethical aspect. So with this brief introduction, I hand over mic to the moderator, my co-moderator.
Thank you very much, madam. Very good morning to all of you. Myself, Roma. I had a great attachment to Assam because my root started from here. Holding the hand of my teachers, I am standing here. So today's session, generally, as an introduction, I want to tell is that though India has progressed a lot, enhanced in good care in mother as well as children. But the thing is, yet there are certain deficiencies in maternal health care providing, and also neonatal problems or fatalities. And there are certain issues related to areas where underprivileged areas are there, where midwives are still, we are not able to provide them for providing good care. So midwife is the only person who is competent enough to fill this gap. So especially this plenary session of today, it aims to provide, to give all of the midwives who are interested the abilities, the information and the legal assistance to provide high quality care. So among us we have three eminent speakers, and I'll hand over the mic to our chairperson, madam. She'll introduce and kindly.
So our first speaker, three things we have to keep in mind, three C's, that we need competency, we need confidence, and we need compassion to practice our maternal and childhood care in the clinical area. So let us first invite our first speaker, Mrs. Sheetal Samson. She is the principal of Fernandez School of Nursing and head of National Midwifery Nursing Training Institute of Fernandez Foundation, Hyderabad. She is practicing nursing educator, midwifery educator, and program lead nurse practitioners in midwifery education, program mentor, midwifery program in the states of Odisha, Andhra Pradesh, and West Bengal. She is co-author India adaptation of WHO Essential Childbirth Care modules. She is former Dean in Academics of Krishna Vishwa Vidyapith, Deemed University, Karad. She is founder principal of GAMS School of Nursing, Rohtas, Bihar. She served as board of directors, member of SFI Medicare Private Limited India branch of serving Friend International of South Korea, and various presentations and publications on national and international platform and journals for maternal and newborn care and midwifery in India. So let us listen with the topics on strengthening midwifery education and training, with the highlighted points on enhancing curriculum and clinical training for midwives, hands-on skill, importance of hands-on skill development in antepartum, intrapartum and postnatal care, and role of simulation-based learning and mentorship. Hand over, madam. Madam, thank you.
Am I audible? Yes. Thank you very much, Dr. Datta. That was a wonderful introduction, and I'm so humbled by the crowd that we have today. And my greetings to the audience and the array of flamboyant dignitaries that we have on the stage and off the stage. So I'm here today to speak about the strengthening of midwifery education and training. This is a very close topic to my heart because I am a midwifery educator, a clinician, and of course the principal of the National Midwifery Training Institute as well. So I begin by saying having access to a midwife is a basic human right for all women, and I quoted by the
so many, there is a gap between the theory and practice. So actually what we are practicing in our State Midwifery Training Institute and what is the progress we have taken in the state of Andhra Pradesh, we will have a brief glance in that presentation. Thank you. So preparing the midwives for maternal and child care in India. Next please. So this is a brief table how the midwife has embarked in AP in the month of September 2019 and it has started, and now at present we are in January 2025. So let us, next slide please. So background, AP is one of the largest states with 9 lakhs of pregnant women as well as 8 lakhs of annual deliveries. Government of AP has made significant progress in achieving key MCH indicators. In this progress, even though the achievement is there, some of the lacking and challenges are there, like C-section rate is over and overcrowding of higher facilities as well as over medication. State has faced the challenges in ensuring respectable maternity care, improving the quality and availability of trained resources. To address these issues, Government of AP has planned to build a strong midwifery cadre. So as we were discussing in yesterday, launch of guidelines on midwifery services by Government of India Partners Forum in the 2018. So this was the initiation which has taken place in Government of India. So followed by that, the AP government has started so many sensitization meetings with Principal Secretary, Health, Commissioner, Family Welfare and all stakeholders. And AP has decided to roll out the program by creating a cadre of midwifery practitioners in public health hospitals. And it has formed a task force with 3 members. One is a Commissioner and Government of AP, and that is a main drive. Then it is associated with Fernandez Foundation. It is giving technical support as well as training, and UNICEF, it is giving the advisory committee. Next please. Develop state level roadmap for midwifery initiative. Director of Medical Education, after conducting the assessment, they have identified 10 colleges of nursing are the ideal source, and they have initiated the SMTAs in the Guntur as well as in Tirupati. And even the budget has been sanctioned. In the year 2021-24, 2 batches, approximately 8.6 crores have got approved. And for skill labs and training, before launching of the NPM centers, they have given 10.25 lakhs for each SMT, where we were able to establish the equipment, what all are required, simulators and all the things, hostel and college equipment. 12 midwifery educators selected as per GOI guidelines and trained for 6 months at NMTS Hyderabad, like Fernandez and even Bangalore. So let me comfortable. And this is in the before starting itself, the budget is also been allotted in the state of AP. That is one criteria. And the first state in the country to have GO for midwifery. So we haven't just started as we like. The GO Government of Order 2005, GO number 205 in the year 2022. We have a guidelines. This GO has given each and everything. So how it was formulated, 4-5 GOs come coded together, and how to appoint the NPMs, how to appoint the NPs, the budget and selection, even criteria, theory, how many hours and practicals, internship, lab, everything is given in detail with the GO. So with the GO, I think this is the first opportunity we had. GO clearly outlines implementation and guidelines. Applications were called for 60 NPM trainees in service staff nurses who are having regular or contract basis staff nurses were taken, and they were being sensitized, and we have given so many examinations like OSCE interviews, and structured questionnaire is also being given, and formulated the NPM selection committee from Commissioner Family Welfare, Director of Medical Education, Colleges of Nursing Principals, and UNICEF and Fernandez Foundation. So out of 139 applied for first batch, we have taken scrutinized and we have selected 60 candidates were selected. Budget 94.8 lakhs were given for 2 SMTAs and 1 data operator, data DEO also been given by the Director of Medical Education. Midwifery program launched by Commissioner Family Welfare in 17 February 2022 NPM. So you can see the picture. The first picture is a Commissioner Family Welfare. During COVID, they have started what is the CEC material and how they are used to take. This is our laboratory, NPM lab in SMTA Guntur. Next please. So as per GO, State Nursing Council has conducted an inspection and has given starting permission and had to give the recognition permission because 2 years have to be over. The BEGNAM board examination for GNM under Director of Medical Education, they have conducted the exam. So many queries have developed during the examination. So their pass percentage is 70%. So we have interacted with Indian Nursing Council for so many clarifications and they came to know. So on the eve of International Day, Midwife Day, the MLCUs, it's not only the college is uplifting out of the nurse practitioner midwife program, even the labor rooms or the labor departments of the maternity departments of the GGH, government general hospitals, are also uploading because this mid-level care units are being given 6 lakhs of budget and with that they have uplifting the educational material and the beds and the simulators and the balls, etc. 18 months theory and practical exams conducted by Nursing Division, Board of Examinations under DME for 2 batches over. Even 70% is the pass mark, so some of them are supplementary and that is also over. All 60 midwives are posted in 13 high delivery load hospitals. So it's a dual role. So if there is a batch is going on, these educators are giving training to the midwives as well as they are mentoring and they are posted in the areas. If there is no training program is going on, they are doing morning, evening and night shifts in the maternity departments of the given hospitals. All 60 midwives in the first batch, 30 from one SMTA Guntur and 30 from other Tirupati SMTA, all 60 midwives were posted in 13 high delivery load hospitals in batch of 4 to 6 hospitals. So they have immediately taken and then posted according to the number of deliveries happening in the area. NPM certificates issued by Board of Nursing Examination under DMA. See, our batch of 60 midwives have been given course completion certificate as well as marks memos. But at it, the registration has to be done. In the State Nursing Council, apart from the other ANM, GNM and all, now they are initiating the course of registration nurse practitioner midwives as well as educators. It is under the process. So as we all know, and since yesterday we are seeing, so these are all the birth positions and they are literally practicing with the mothers and exercises, what they are doing in different positions. Next. Monitoring and mentoring. This is continuously, it is monitoring with the help of the team, Commissioner Family Welfare as well as Director of Medical Education, SMTA principals, and with the help of UNICEF and Fernandez Foundation. Totally the participants are doing that. Periodical visits are happening and they are mentoring the other educators also on the regular basis in a hand holding of MEs. Regular workshops like moms, optimal birthing position, episiotomy works, etc. were organized. So apart from their routine work, they are continuously enriching with the knowledge as well as skill. So continuously from the Fernandez Foundation, UNICEF, they have repeated trainings. And these are all the material they have developed. Optimal birthing positions, State Midwifery Training Institute is also having some guidance note. The posters have been sticked in all the areas of the maternity wards. Next please. Next. IEC package of midwifery services. The budget is also being sanctioned to the MLUC so that so much of the education material has been given for the health education process. So they are all safe motherhood and antenatal care book, postnatal counseling and HR pregnancy, antenatal exercises. Some videos are also we are displaying in the areas of OPD where the mothers are waiting. So unnecessarily they are waiting. Then in that time also we are utilizing and we are projecting these videos to take about the antenatal diet, exercises, and how to take care. Even in the first stage, on the last trimester, mothers also being given how to cope up during the first stage, second stage, and all. These are all the videos also we are utilizing for the purpose of the mothers who are all coming to the GGH hospitals and who are under the care of these SMTA and MLCUs. Next, please. After posting of 60 midwives, a team of the people are sensitizing them. See, there are some challenges. Even though it's going on, the challenges starts from the institution. So continuously, the sensitization programs are going on separately with the obstetricians, with HODs, with the nursing department. That is the one we are facing. Our nursing superintendents itself are sometimes they are not cooperative. These educators or the midwives are being posted to the different wards and all. Go on sensitization programs we are giving for the staff on midwifery, and we have even conducted sensitization for medical superintendents, obstetricians, midwives, nurses, and other maternity staff. SOPs, guidelines on optimal birthing position, and midwifery advocacy videos were shared. Demonstration of exercises and optimal birthing. So this is one of the area where it is attached to the labor room. So they made the mothers also to do this. Next, please.
Excuse me, madam.
Ma'am.
I'm here.
Time is over.
2 minutes more.
Okay. Then physical monitoring of the sessions, please go on. Next, please. Virtual, not only that physical sessions, virtual midwifery mentoring sessions also being given. See, virtually they are giving 20 sessions has taken with the awarded 12 credit points. This shows that we are not even giving a formal training to the educators as well as midwives. So continuously one or the other is going on and they are doing dual role. So helping the mothers as well as in the teaching side. So this is showing 12% of total OPD, 87% of mothers were assessed and given childbirth classes, 42% of normal births contributed by midwives, and this is all going on taking place. Next, please. See, this is a slide showing the midwifery OPD services in different district hospitals and how the midwives are conducting OPD services and childbirth education classes are going on. Next, please. This is a cesarean bed, normal births, how it is happening from the October 23 to September 24. 1 year estimation they have given. See how drastically the LSCS has come down. The red line showing. And this is also the same year we have monitored the midwifery births and births without episiotomies. So on an average 60.5% of births are supported by midwives. 19 births were supported by doctors and nurses without episiotomy. Next, please. See, 79% of the deliveries who have conducted by midwives, 79% has conducted in this upright position, 0.4% only in all four position, 4.6% they have conducted in left lateral, and 16% is in squatting position. So it shows, this statistic shows that the mothers are willing to deliver in the different positions. Of course, we come across so many challenges. The selection itself is becoming the challenge. Once they have selected, they are not continuing. The challenges because of their family problems, or sometimes transfers are being taking place, sometimes promotions, or their medical officers are not going to relieve. So these are all some of the challenges we faced. Next, please. So action plan. What is the action plan? So it's not stopping. There is so much of reviews are taking place in the Office of Commissioner Family Welfare with the Secretariat. The drafting of all the separate cadre, scope and their recruitment, their promotions, all the cadre is in a drafting position. It is sending to the government for approval. And then next is all the, we have recognized 191 public hospitals. They are located in the tribal region. So those hospitals, I have given the table according to it. We wanted, the government of AP wanted at least 1 to 2 midwives has to be placed in the tribal areas where literally they give direct care to the mothers. So this is the process taking place nowadays. So we are going to select 190 staff nurses, and one more achievement is 4 SMTs are also started. The one who has selected 60 midwives are posted in the 4 new hospitals. So total 6 SMTs are working. They are doing their level best, and these 190 midwives also going to post on those 4 areas. So within 1.5 year, after this completion, the government is planning to keep them in a tribal area. Next, please. So recently, the government, this is an example of this thing. This is the second batch. December 24, it has started. The second batch, the theory hours are completed. This is our college. And they themselves, additional director and the member from UNICEF and the DMHO has came and issued the kit. Kit consists of miles textbook and fetoscope, inch measuring tape, and one tab also being given for monitoring of the partogram as well as for the maternal auditing and all. Which means they are going to the clinicals. So way forward, we have to have still the work is going on the scope and the cadre of the nursing profession. And provision, they are thinking of giving performance-based incentives also for midwives. At present, they are getting 5,000 per month and free of accommodation and books and everything, food and all. Then even educators also giving 15,000 per month extra remuneration. Moreover that, they wanted to plan incentives according to the work based. And midwifery cadre and career progress is on draft prepared, and 10 more MLCUs have given, 6 lakhs are being given, and it is operating by the GGH superintendent. Process of registration is also going on, taking place. So this is an actual thing happening in our state. Next, please. So thank you all, and because yesterday we were discussing, since so many things we are discussing, but actually 99% of the theory what we discussed, and it is all taking place in the state. And all the SMTAs, even the doctors also first beginning they were reluctant, but now they wanted. The trials is formulated at the beginning of the ward, OPD, antenatal OPD. The midwives are being given one small room. They have prepared a trials. From there itself they are categorizing who will go to the MLCUs and obstacle cases. Then itself it is easy. Doctors are also encouraging them to please take the cases, and they are following. So each midwife is taking their biodata in detail. They are seeing that personally. They are calling them and they are giving mentoring and clarifying their doubts. And really they became one of the family member and go on talking to them, and they are giving total care. And they are also happy. The mothers also happy to deal because they are having full of trust, saying that no midwife is going to stand with her in this purple dress.
Okay, thank you, madam.
Okay, thank you. A small body of determined spirits fired by an unquenchable faith in their mission can alter the course of history. I have taken a quote from Mahatma Gandhi ji. Thank you very much for giving me this opportunity.
Thank you, madam. It is very excellent presentation. It is very nice to listen from you about your detailed experience, but due to time constraints, sorry for interruption. So you have highlighted about the need for midwifery education and training and legal aspects due to increase in cesarean section. You have highlighted about what happens in your state in Andhra Pradesh regarding budget, training, examination system, and based on what policy you have followed these things, how the midwives are practicing in your states, you have highlighted in details, and importance of sensitization and action plan for the future. So, Madam Yetal Bhatia, she will present on expanding the role of midwives in midwifery, maternal and child health care, promoting the midwifery-led care models for safe deliveries, integrating the midwives into primary health care systems, especially in rural area, and promoting postnatal and newborn care, including breastfeeding support. And Ms. Ekta, she is lecturer and senior scale class 1 from Gujarat Institute of Nursing Education and Research, Government College of Nursing, Ahmedabad, Gujarat. She is chapter secretary of SOMI Gujarat chapter. She did BSc Nursing and MSc Nursing in Obstetrics and Gynae Nursing from Government College of Nursing in Genera, Ahmedabad. Currently pursuing PhD Nursing, over 20 years of experience, 2 years work experience as staff nurse, 5 years as principal in private college of nursing, and 10 years as working in Government College of Nursing. She is nurse practitioner midwifery coordinator and nurse practitioner midwifery educator faculty at SMTI and NMTI in Government College of Nursing, Genera, Ahmedabad. Thank you, madam. Welcome for your presentation.
Okay, thank you so much, madam, for your this nice introduction. Good morning to one and all present over here. all respected chairperson, moderator, respected
guidance and contribution, even moving forward from, as the previous speakers have already highlighted, that the curriculum requires revisit, policy requires to be strengthened and formulated at each stage, as well as the robust system of continuous professional development of midwives and renewal of registration required to be forward way we require to implementation in the midwifery model of healthcare. So thank you, Madam Mohusha, and welcome.
This particular panel is mainly organized by Japaigo people. You know, they are the main people looking after this MLCU thing that is coming up, all over India. And I had the privilege of meeting Punita Madam sometime back last year in Jaipur. We met earlier, yeah. So I am very happy to introduce Madam Punita. She is a Army official. Dr. Brigadier Punita A. Sharma, retired. नहीं मैं तो पूरा ही बोलूँगी. Okay, she is technical director HRH Japaigo. नहीं मैंने बोलने दीजिए ना. People should know. Wait, just wait. Okay, she was former principal and professor College of Nursing AFMC. We are very familiar with AFMC. AFMC is with SOMI. We had Madam John, yeah, very much with us. Okay, and then you were also Army principal at headquarters Southwestern Command, Jaipur. As Madam says that don't ज़्यादा नहीं बोलना है, तो I'll just say a few things. Brigadier Punita, she joined military nursing services in 1985. She graduated from AFMC College of Nursing, Pune. And after commissioning, the above mentioned officer was one of the few graduate trained nurses of those times who were posted to both peace and field stations, station hospitals. Her skill and knowledge has enabled her to provide basic and advanced nursing care to wounded soldiers, antenatal mothers and children and dependents.
Thank you so much.
Okay. I'll just finish it. She's doing her PhD and she's very enthusiastic, and we are very happy that army personnel are taking interest in civil, in areas of maternal and child health. We welcome you, and most of the work will be done by her. I will be sitting here just if I feel anything that needs to be said, otherwise it is her panel discussion session today. So welcome Dr. Punita.
Thank you, Madam, and for those kind words and introduction. I remain humble, and I really would like to contribute in the public health, taking nursing and midwifery both forward to the highest level. That is what I imagine and visualize. And now I must thank SOMI for giving us this platform where we are having a different expertise as a panelist with us who can give us bird's eye view how this midwifery model of care we require to undertake, which is in line with WHO guideline of strategies, which is their 24, how midwifery model of care has to be implemented in the country. So before we could go further, I would like to introduce my panelist. To my left is Dr. Amit Nagra. I need to breathe a little bit because it's a very... So he is a person who is working with World Bank, and he is a senior health specialist with health, nutrition and population global practice of the World Bank. and he has a PhD from Social Accountability and Health from India. Over 20 years of experience in development sector and working with several countries, South Asia, Middle East, North Africa region, and possesses a wide range of understanding about different contexts, fragmented institutional system, policy constraints and challenges related to human resource, capacity and optimization of allocation of financing, contract management, and he is currently leading projects as task team leader in India, which focuses on health system strengthening, health access and service delivery, quality of health services in secondary care, public hospital, equity, utilization, issues in primary health care, and has implemented numerous interventions at all levels. I also would like to mention here he is also instrumental in giving ASSIS project his hand in the development of health infrastructure, healthcare delivery in the state of Assam, which yesterday PD sir, Dr. Siddharth Singh was mentioning. Extreme left is Dr. Vikas Yadav, who belongs to a Gates Foundation and he is working as a Deputy Director Family Health, and he is responsible for leading the family health portfolio spanning maternal health, newborn health and family planning, nutrition and large-scale food fortification areas of work. If you recollect recent news, there are a lot of funding which is there towards nutrition upliftment, because the studies also have indicated that nutrition of mother as well as newborn during pregnancy affects the health outcome in the adult life of a person. So it's very great area. And prior to this, he worked as a senior program officer in the state health system strengthening team and led to lot of RM and CHA and work in Uttar Pradesh, including the technical support unit and primary healthcare intervention. A well experience in the field of public health, more than 20 years, and he has worked as a program director with our organization, I must mention, in Japaigo, and from there he has moved on to Gates Foundation. We are waiting for Deepika to come. Now, right to me is Mr. Jinu James. The policy maker make the policies, and Jinu is instrumental in implementing this policy in the state of Bihar. How midwifery has rolled out, how the government machinery has been activated, how they have involved, what advocacy has done. He is a nurse by profession, MSc in community health nursing, having an experience of more than 15 years working in the field of nursing and midwifery at the state level. Presently, he is a senior program, state program manager at Japaigo in the Bihar branch. So, meanwhile, we wait for Deepika Khaka to come as nursing advisor. We proceed with our panel, and I would like to change little format because it's already 10:30 and we have a very hard stop by one of our panelists has to move. So I'm just changing a little pattern of my asking. So, Dr. Vikas, I would like to ask you first, how are we going to show that alignment of NPM and NP program and mainstream midwifery in our health system?
Thanks. And I know we are waiting for Deepika ji, who would be the most sort of appropriate person to talk about, some of the policy work to integrate NPM as a part of health systems. But I can share what I feel, are the appropriate steps. And I think, a lot of previous sort of speakers also mentioned challenges in areas across cadre integration. I think that's the most important step to process, and I think from a national level, there is guideline which is available, and there was sort of career progression, cadre integration, indicative sort of guidelines also for the state. But really, the work is actually at the state level. Health being state subject, this integration approach will have to be led to the state. And I think two important steps there. One, obviously, making midwifery right now still the midwifery cadre itself is.
Dr. Vikas, I think I just asked to ask audience, are you able to hear clearly? I could see some confusion. The audio is clear, Dr. Vikas, can you hear it from the last bench? Just raise your hand. It's okay? Alright, okay, please continue.
Thank you. So the first step is actually really making it is a part of the overall nursing cadre of the states, and there, the sort of the whole process of making it a sort of fully state-funded position to creating pathways in which not only we bring nurses and midwives from sort of external environment into the system, but also helping people within the system actually grow and become midwives and then pursue a further career. And I think career progression, as a part of this stream actually is an important step, and it's going to require like substantial both sort of mobilization at the state level, but also resource investment by the state governments and any other support functionaries which are there. So that's really the first step and most important step to integrate as a part of the approach. And second is actually to strengthen the pipeline of midwives or capacity build midwives as a part of the process. And when the cadre was introduced, there was at that point in time what was seen as an appropriate process to build this pipeline of trained midwives into the system was set up. So for instance, we had sort of this provision of national midwifery training institutes, and then state midwifery training institutes, and then subsequently sort of helping build this sort of group of people who can actually subsequently be absorbed in the system. So I think that system has worked in the early or inception phase well. I would say, although we still struggle with state midwifery training institutes and bringing enough midwives from the system or recruited from the system to actually run through the training programs. But I think it has more or less worked well over the last few years. Now as we expand this network, I think the expansion of state-based training institutes and fast tracking availability of midwives as a part of the process, I think that's the really important next step. Add to this is actually effective integration will not happen unless we demonstrate effective caregiving. And I was really impressed with some of the presentations which AP team was doing, demonstrating. And I've seen data from midwifery program overall, and the kind of demonstration on improved outcomes, patient level outcomes or client level outcomes on quality of care. I think that's really important. For that to happen, beyond the existing SMTIs and the midwifery-led care units within SMTIs, which we are supporting, which are largely in a teaching construct, I think we have to expand the midwifery-led care units within the broader health system. And alongside district hospitals or CHCs, FRUs, if we have these care units totally fully led by midwives and demonstrating the quality of care and the continuum of care, I think that will build confidence within the system to actually take it up seriously and then make it a part of ecosystem. And the fourth thing I think which we should and need to do, and which is happening right here, one of the things which we, when there were conversations with Government of India, which we really struggled with, was this broader awareness about the cadre, and it being an aspirational thing for nurses and midwives to actually enter into the system and see it as a sort of career opportunity. So I think having more such sort of opportunities where we can share what this cadre of workers mean, how does it improve, what is the career progression, what are the opportunities. I think that will create also a sort of network of people who are interested in becoming midwives and becoming part of the system. So I think that's equally important apart from the state level interventions or system level interventions which we plan to do and intend to do. I'd say one more thing which is like slightly not conventional, but I guess a broader overall sort of framing of opportunities within this cadre could also be evolved. So the whole ability, we have been for, I think, we have sort of eminent speakers here and who's who of nursing profession here. And there has been a long-standing sort of push to build nursing as a profession which is leader not in caregiving but also in research and sort of broader public health, etc. And I think if we can set it up that way and also create opportunities to test and layer and develop innovations, I think that's also another way in which system would also be more amenable to integrate midwives as a part of the ecosystem. So I'll stop here. I'll see if there are questions. I can answer more, but thank you so much for giving me the opportunity.
Thank you, Dr. Vikas. Would you like to say something?
Dr. Vikas, you very well said 3-4 points. That's how we can promote midwifery-led care, the program that is going on, creating more opportunities. We would also like to maybe at the end, how are the takers taking it? The NPMs that we asked to join. What is their reaction, and the educators also. Maybe at the end. Thank you very much.
So my next, thank you Dr. Vikas, and my next question goes to Dr. Amit. Now Dr. Vikas was saying like state level how we are working and how policies are taken and what. I would like to ask you, what strategy should Government of India employ to effectively integrate midwives within existing healthcare system? How they can be embedded, how they can practice midwifery as a part of this larger health team. Over to you.
Thanks. Thank you for the question, and nice to see all the people from the whole fraternity of midwifery and nursing. And happy to be here, bringing a little bit of gender balance, and it's probably important, when we talk about this topic. So I think the question which you have asked has been, largely answered by the earlier presenters. I think what is needed is being pretty clear to all of us, but how is something which is going to be a little difficult. And the way entire health systems in India is evolving, transforming over time, I think I see a greater role for the midwifery moving forward. When we are talking about the shortage of doctors, the specialists, I think there's another category which needs to step up. And that's nothing other than midwifery. Creating the cadres is a no-brainer moving forward. But how are we going to make that happen is something which is very critical. With the task shifting and change of roles of different people who are working in the larger health system, starting from the government's role, and this is my very favorite line which I say that the role of government has been changing significantly, starting from the provider to the purchaser, right? And similarly, within the health system, how are we going to change the role of ours is very critical. On the other side, it is also important to see that why only the government sector? If it's true that half of the deliveries are happening in private sector, why are we also not trying to create the avenues, the markets which are currently evolving and looking for the better birthing spaces or better health services? I think that is where we play a very critical role. And again, I would like to link this with the quality part because I think the demand for health services have changed over time. Access is no more a problem in India, but I think quality is, and that is where I see a greater role of midwifery. So it is more demand driven, which is going to happen moving forward. And we all know that if you look at the maternal deaths, close to about 50-52% of them are actually falling under the low risk category, right? That clearly indicates that somewhere we are compromising on the quality. One of the earlier presenters did talk about the C-sections. It's pretty high in India, right? And do we see a role for midwifery to play in that? There is a very strong evidence which talks about how midwiferys can actually bring down the C-sections, and this is largely the unnecessary medical intervention which is needed. So, in summary, what I feel is it's not only finding the place in terms of creating a cadre within the government, but beyond that, I think we should also look at the private sector in order to see how we can find a better role for midwiferys to play. So let me stop here. We can take the questions going forward.
Thank you, Amit, for this giving us. Please. Yeah, so our panelist, there was some confusion regarding Dr. Deepika's vehicle. Welcome, Deepika. Please come. So I think we have little interjection during the presentation on flow panel. I would like to introduce Dr. Deepika to the group. Dr. Deepika Cecil Khaka is a distinguished nursing professional with a PhD and over 37 years of experience in clinical practice, academic research and administration. As the nursing advisor to the Directorate General of Health Services, Ministry of Health and Family Welfare, Government of India, Deepika plays a very pivotal role in shaping national nursing policies, guiding workforce development, and strengthening nursing education and service across the country. With 72 research publications garnering almost 1,000 citations, she has significantly contributed to nursing scholarship alongside authoring one book and contributing chapters in 4 others. She has 8 award papers to her credit, presented at abroad at the international platform, and actively developed various national and international policies, documents, guidelines and learning resource packages, which has influenced healthcare education and professional standard. Well recognized for her contribution, she has received 8 prestigious awards and 2 esteemed fellowships, including a Fogarty Fellowship at New York University and Advanced AITRP Fellowship at University of California, Los Angeles. A Global Nurse Leadership Institute scholar, she has an educational board of member for 5 journals, a peer reviewer for 18 national and international journals, and a PhD guide at the National PhD Consortium. She also serves as a doctoral research committee member at AIMS and IGNOU, and furthering her impact on nursing education and policy. Over her career, she has guided 1 MD, 9 PhD and 56 MSc students, further contributing to the growth of nursing education and research. I welcome you. So, we start with our first panel, which was very apt question for Dr. Deepika. This was how the education in midwifery what institutional innovative approaches we should incorporate in our program design to ensure that midwives are equipped with the necessary competency, compassion, and which are able to provide high quality midwifery care. So over to you.
Well, thank you, Brigadier Punita, for those kind words. And I'd like to thank the organizers for giving me this opportunity to be a part of this esteemed panel. As we all know that the healthcare indicators of a country, a very sensitive healthcare indicators of a country are maternal mortality and infant and neonatal mortality. And how we can take care of this very sensitive healthcare indicators are that we educate and give the necessary competencies to our midwives. We have substantial evidence to prove that, and there are many success stories which are there, like success story of Sri Lanka, whose maternal mortality dropped significantly once they trained their midwives, and so is the success story of Sweden. And in Sweden, in the periphery, there were lack of trained doctors which were available, so they had trained their midwives, and thereby it showed a substantial difference in their maternal and neonatal mortality. So it is imperative for us to train our midwives, because as we know, midwives save lives, and if we train them with the necessary competency and skills as per the INC and the ICM competencies, that can make a phenomenal difference. Now, as educators, as trainers, as policy makers, there are certain things which we have to keep in mind in training our midwives, the necessary competency they are required, right from preconception, antenatal, intrapartum, postnatal, and family planning choices. What we can do first thing is that we have to have a competency-based curriculum, and we have a very robust competency-based curriculum, not only for our undergraduate and postgraduates. The Government of India has also launched a flagship program of midwifery initiative in which we are making MPMs, nurse practitioner midwives, and we have MPMEs, nurse practitioner midwifery educators, who are training these MPMs. So we can have a competency-based education in which we give them hands-on training, decision-making power, autonomy, how can they respond in emergency situation, and also advocacy and leadership. Then we all know that we have recently got an INC curriculum, which is a competency-based curriculum, which has been rolled out in 2021, which speaks of simulation-based learning in a very big way. And if we have simulation-based learning, we have high-fidelity mannequins, which can give the hands-on experience before going to the real setting to the students or to the midwives in the making, so that they get the necessary confidence, competence, skills, dexterity and precision in doing the procedures and doing the services which they are supposed to be rendering. Then we all know that assessment and evaluation is also a very important component. We can have skills, we can assess skills through OSCE. We can have a structured examination pattern through OSCE, and competency-based assessment can be done. And so a robust evaluation system requires to be done. The Government of India has this program, which is National Digital Health Mission, which speaks on providing access to services which are not available through digital platform. So blending learning of in person and also through digital platform, which can be used in a very big way, in which we can encompass like case-based scenarios, mentorship programs, improving accessibility and enhancing the learning outcomes. We all know that training is a very important component. Training in all sectors, like training in high load facilities, training in tertiary care, in primary care. So the midwife should be having exposure to all different sets of healthcare facilities, so they become robust in whatever they are doing. And respectful maternity care is very important. We know the Government of India is now focusing and in a very big way highlighting the need for institutional deliveries. That is making the load on obstetrician, there's a substantial load on the obstetricians because of the focus on institutional delivery. Thereby it is very important that we have a midwives who can handle the normal physiological labor, and for that they have to have that basic ethics have to be inculcated regarding delivery of respectful, culturally relevant care to the mothers who access any healthcare facility for maternal and child health services. Also, we have to strengthen them in emergency care, in neonatal resuscitation, in obstetrical emergency management, in case if required, managing complications like sepsis, eclampsia, postpartum hemorrhage, and how to in a skilled way do neonatal resuscitation. So these are some of the things which we can do to have a robust system so that our midwives are competent. They have those ICM core competencies which are required for them to function in any healthcare facility. And once our midwives are competent, there will be substantial drop in the maternal mortality as well as the neonatal mortality.
Thank you, Dr. Deepika. We are happy that you are from Government of India and also connected with INC. And NNMC is coming up, so we are very hopeful. The things that you said, it should start with the education. Although we have 18 months training that has come up for the for NPMs, but we need to work at the same time. We need to work with the curriculum which we are following right now for the BSc level, GNM level, to make it more competency based, similar, so that we don't have to again train these people again for that advanced midwifery. So there is a need to change the policy. Madam is from the policy makers, from the Government of India. So we have we are so happy that she is here, and all these 3 days we are going to talk about how are we going to influence so that we promote midwifery-led care through from the base itself. So base we need to think again, and this is going on, and for that also we are discussing what is the present scenario of MLCs in different states and how we are going to improve it. You have very well said that there is assessment, evaluation, and at every step the competencies midwives need to prove themselves. So thank you, and let's hope that this panel and this whole program give some inputs into how to help improve midwifery model of care. Thank you.
Thank you, Madam, for those wonderful remarks. Now, I also feel that we have a substantial number of NPMEs who are trained pan-India. So I feel there should be a platform where all these NPMEs are connected, and not only connected, they interact with each other and they require to work together. How this can initiative with midwifery model of care Government of India is thinking, how it can be practically taken forward, because they are the people who are working at the ground, who are working with the people, with the collaborative team, with the neonatologists, with OBGYN, and with the hospital administrator. So day in and day out, they are in touch with them, interacting, hurdles are there they are facing. So that is one aspect. I also feel that somewhere that feeling of that I am a competent, practicing, professional midwife, that professional empowerment within self to do work for what you are trained is very important, whether policy is there or no. First, you are a professional. So we need to, policy will follow. It takes time. We have seen it takes so many years, 5 to 10 years is a minimum journey which policy implementation takes place. But I think if we are able to prove ourselves and show to the world, yes, policy is coming, we are working for it, but we are a professional midwives who are very convicted for the cause of maternal and child health, I think we will be able to make a difference. With this, my next question comes to you. How the government of Bihar is looking for Ministry of Health and Family Welfare vision for role of midwife in achieving the Bihar health goals for the state.
Yeah, thank you, madam, for the wonderful question. So, as I am working as a nursing consultant in nursing directorate, that time midwifery guidelines have been passed in 2018. So that time itself, our principal secretary Sanjay Kumar sir has taken this initiative very seriously and told me to make a draft of vision document. So from there to till date, I can say that Bihar is one of the state is very supportive to this program, and very seriously they have taken this, and still we can say that our second training is happening at SMTI, and so many SMTIs are establishing and MLCs are also. So I think the guidelines from Ministry of Health has been already implemented there, and we also put a cadre rules for the NPMs. So we try to make it as that also possible. And coming to the vision document, I can say that in 2020 itself, we have finalized our roadmap for the midwifery initiative in Bihar. So in the roadmap itself, it is very clearly, we have given the timelines as well. For within 6 months, we have to establish our first SMTI, because in guidelines itself, they have given that the state nodal center has to be taken as the SMTI. So thank you for the guidelines for this, because otherwise we would have a confusion, because which institute we have to select first. So we have followed the guidelines only from the Ministry of Health, and we have framed the budget in PIP as well, and we have got the budget. And from the time 2020, we have started and initiated the work of SMTI, our first SMTI. But due to the COVID, we all know that due to COVID period, 2 years later only we have inaugurated that SMTI during the time. So we have started our first NPM training in 22nd February 2023. But even though there is so many process we have done in between as well, so many sensitization meetings, I thank Bihar Nursing Council for the support. We have conducted 12 webinars during the COVID time, 12 webinars for midwifery initiative, and due to that only we have got our first 6 midwifery educators. They have got training from NMTA Varda. I would like to thank that NMTA Varda also, because they have made a wonderful NMTA and MLCU. We went there and we have learned a lot, and with the support of them, our 6 midwifery educators back in Bihar, and now they are working, and second batch is going at IGMS. And also we are planning our second SMTA in NMCH, and we can say that our second batch NPM also went to NMTA Varda now, and hoping that they will back by after 4 months, because it is started 2 months before. So hoping that within 1 or 2 years we will have 4 SMTIs and also 10 MLCU we were planning. So all the process we have done according to the guidelines of Ministry of Health only. Even the selection process also we have followed the guidelines from Ministry of Health. All the process we have done. For example, the examination, if we see, we followed theory, OSCE and interview. So we didn't cut off anything from the guidelines. We still following strictly for the guidelines, and hoping that the program will continue and it will be great success. And I request other states also to try to finalize their roadmap first, because the roadmap is very important document, because without roadmap we can go ahead. So according to the guidelines we can make a roadmap. And also the institutional setup also is very important, like state midwifery task force we have to set up. See, in Bihar, if you see, we have set up. So in Bihar, the importance of institutional setup also is very important, because without task force we can't have any, means it is a committee under the chairmanship of Director in Chief, and the members, all the partners and all stakeholders like SPO Nursing, SPO Maternal Health, and also including the principal of SMTIs and the other principals of College of Nursing, and all the development partners are part of that. So registrar BNRC as well. So they are while meeting itself, we will finalize so many things. So they help. It helps us to sustain this and maintain all the process and timelines in timely, and that's why we have achieved these things. And I think I have answered the question. So if you have any question, I'm happy to answer after the sessions.
Address the question answer little later. Yeah, ma'am.
I'm so happy Mr. Jinu is here. I visited Bihar twice to see these MLCUs, and I met those NPM students also. Very well going on program. I mean, and really the teamwork that you have with the government officials, nursing colleges, principals, our SOMI chapter secretary is there, the principal of Government College of Nursing, and it's an example that they started late, the program of MLCU, this advanced midwifery, but they are going ahead in the country, and that is what I found, and he also has explained. Thank you, Mr. Jenu, very nice.
Thank you, madam, for your input, and thank you for appreciation too, because I want to become part of that organization who's implementing, and Jenu is there. So we have seen and we have come to know that yes, midwives have to be integrated, but any thing new which comes into system brings its own challenges and some benefit. So Dr. Vikas, what do you think with your experience? You have seen so much policy changes, different field also. So in nursing, this change which is coming, midwifery model of care in India, what are the challenges and benefit we can have as our beneficiaries in the public health system and long run in private sector too?
Thank you. And the private sector point, I think, was really important. I mean, long-term sort of cadre building and integration, I think, requires this professional development opportunity and also career opportunity. So certainly, private sector should also be seen as a place where people can get as an opportunity to get into that space. And some of the states have actually looked at that. But quickly answering your question, and I'll also answer ma'am's question on how they are feeling. I mean, the NPMs are feeling being part of the system, and what their thinking is. But quickly to answer your question, I think everyone has said. We've seen in other contexts. Deepika ji also said, there is evidence existing that certainly quality of care improves, and I think there are dimensions of patient-centered quality of care and also systems benefit as we integrate this cadre, or as this cadre gets integrated into the system. So I'll not get into the patient-centered benefits of quality of care, because a lot has been said: cesarean section rates dropping, birth outcomes improving, the overall human-centered care approach and women wanting that care. I think that's all in place, and we're already seeing evidence to that, both in data and also qualitative insight. So that certainly is there. But I think from a systems perspective, having a sort of cadre worker who can independently manage substantial part of caregiving and complication management, that is a big deal, because as a part of our health systems approach, particularly for maternal newborn health, we struggle with availability of specialist care, and there is also an over-reliance on specialist care, which is often not required. And this is the whole sort of background behind integrating this, newer cadre or midwifery-led care approach. So I think that is undeniable, and if we do it well, and if we structure introduction of midwifery-led care units well as a part of the system, I think that sort of task shifting, reducing over-reliance on specialists and decongesting specialist-led care units, I think that's a fantastic sort of opportunity which we can realize, within not a long or large span of time. So that's another really valuable benefit which we can see. Another thing which I feel would also be useful is, and I alluded to it when I was speaking to the earlier, is also this sort of aspirational cadre building and career opportunities for midwives, for nurses and nursing professionals as a whole, and sort of being specialized care providers and independent, semi-independent, independent care providers. I think that in itself for a health worker is a really important sort of motivator and opportunity, I think, which can be again realized by integration. And then finally, we could deliver many more process and product innovations, improving quality of care again, if we have opportunities for midwives leading care in health systems, and I think that is certainly an opportunity which is to be realized. Challenges we've talked about. We need to sort of have, and ma'am also said, we need to have like a roadmap or cadre integration plan, whatever is required to debottleneck at the state level, this integration, whether it is career progression pathway or integration or positioning, job posting, etc. So all those, strengthening the whole pipeline of sort of midwife educators more at the state level, and the broader awareness within the ecosystem about value of midwifery-led care and creating it as an aspirational opportunity. We keep talking about some bit of resistance with medical fraternity or specialist care. I don't see it as a big challenge. I feel, as we integrate and decongest specialist-led care units, I think there will be much more acceptance. Personally, I have not seen a lot of evidence of this. Some of the, OBGs are also true champions of midwifery-led care. So in our system. So I think that would be something which we, as we engage, we could look at. Ma'am, to quickly answer your question earlier, I think wherever I've seen, the first thing which hits me, these nurse practitioners, midwife, being the system, is the sense of pride which they have, in being, the primary care provider, providing, human-centered care, and also doing it independently. So I think that is undeniable. It's very, very visible. You see them in their uniform, leading care and demonstrating the competence and skill which they have. So that's certainly there. Second is also from a patient's, client's perspective, there is this sense of confidence in their abilities which I've seen. So if people start with them, they want to continue with midwives wherever, we've seen them engaging with them. I also have heard from them some of the challenges which we are talking about, right? So there are teething issues for integration of midwives into the system. Some of the ones who came from within the system, they'll be posted elsewhere, as a part of NSCO, which is not like the most optimum situation for people or sort of women who have joined, this aspirational opportunity. So some of those challenges also keep coming, which we, I'm pretty sure, Deepika ma'am is here, and Government of India is working on it. So I think that. And then finally, I think midwifery-led care units expansion, I think, is another thing which they keep telling about, because that's an opportunity for them to really practice care. But otherwise, wherever we've seen them functioning, I think it's an immense sense of pride and great confidence in what they want to do. Over.
Thank you, Vikas. Apart from this, I just would like to add, midwifery care of model, if it is adopted, it is financially also benefited for the government and the individual itself. So we can save our resources, we can also reduce on the cost which Government of India or any private sector will incur. So that is another aspect, and it also gives a professional identity. Like today, a nurse conducts. The pregnant lady comes in her contact when she approaches labor room. But this midwife who is there with her throughout a journey. So the last minute anxiety in the pregnant woman, really it reduces and makes her very, very comfortable, calm and confident. Yes, my, I may say, companion in this journey from preconception till the baby is birth. So she's there, and I have seen this, and I like when I interact, when person comes and asks, आज वो दीदी नहीं आई क्या, वो पिंक ड्रेस वाली मैडम नहीं आई क्या, and some of them even call by name कि I would like to deliver by this particular person. So as a midwife also we have to think whether we are placing our time as per the request of a pregnant woman. We also require to walk that extra mile, and system also need to think that after that duty roster, if somebody has come, how she has come. Another thing is, when we say about data generation, what midwife is doing, we need to put that in system, how much workload she is taking, and somewhere this data has to be put from the state till national level. Then only we will be able to show it is impactful and how this initiative is making difference in their lives. With this, I would like to ask Madam Deepika. We have seen that this curriculum, which is INC approved, and GOI directives are in alignment with global recommendation for transformative education. I'm sorry I'm jumping here and there, but I think that's the way today panel is. So how do we go about this transformative education? Because certain educational technology and pedagogy which is listed in the curriculum of NPM and NPMEs are quite different, which our older educators also are not completely confident. Simulation is just little one part. Experiential learning, how that can be helpful. So all these new things, how do you think we can integrate with our curriculum? Dr. Deepika.
There is a saying which says change is the only constant in our lives. The sooner we adapt to change, the better it is. And as we know that everything is improving for the good. Like earlier we had no idea what AI is. Now most of the things AI is doing. So similarly we have to have that mindset as educators to be updated with the latest pedagogy, latest educational technologies, so that we can disseminate and deliver the best we can for our students. And learning never ends, it starts from womb to tomb. So the sooner we are updated with the latest guidelines, the latest technology, the better it is for our students. Because student is your ambassador. Like I have also visited, my experience, I have gone to Patna, I have seen the MLCU there and the SMTI, and I have also visited Fernandez, and in Telangana also one NMTI I have visited, and I also have visited Meerut. So they are all doing a good job. But as reiterating what Vikasji was saying, that there are some teething troubles which are going to happen because this is getting integrated into the system which was earlier not there, this cadre. And any kind of change requires some time to fit into the ecosystem. So give it some time, and this is a viable, doable model. And if it is executed in the national level and from all the states, it will make a phenomenal difference. And it has made a lot of difference, as Madam was also saying, that there are a lot of success stories in which women feel more comfortable in delivering with the MPMs because they have a relationship with them. So they are well versed with them. So what we can do from aside from the education part is that we have to be updated, know what the latest things are, and so that whatever is the latest, we can inculcate those necessary skills, knowledge, aptitude, the advocacy, leadership among our midwives. Because advocacy and leadership is also a very important component where your voice can be heard. And as Madam was saying, data speaks. If we have substantial data to say what phenomenal contribution these midwives are making in the maternal and the neonatal health care of our system, which is a big chunk of our healthcare delivery system, I think that the government will listen. And I would also like to say this using this platform, that as SOMI, as a national level association, you should also make your voice heard. Talk to the policy makers, whatever your concerns are, voice it. This is a good platform, the government will listen. So otherwise policy making is generally done by the people who are sometimes not a part of the system. So as SOMI SOMI, you can be you can have a distinct voice and voice your concerns, whatever you are, so that they get inculcated or they get adopted into the policy system.
Thank you, Deepika. So, what with your point, I feel when the conference of such stature and with all expert takes place, 1 or 2 white paper, if can be submitted to the state or the national government, it will make an impact, and we should reach out to the person who are actually implementing policy, formulating policy. This will give a recognition to the professional organization also, and as well as the policy maker also look forward for ground level input when they are drafting. Definitely it will make a difference. So thank you with that. Next question I would like to ask Dr. Ahmed, since you are from an organization which helps the government with lot of financial aspect and we know the money is needed for bringing about at least infrastructure and things like that. So how do you envision the contribution of addressing service disparity in maternal health service, and how organization like yours can make a difference in infra as well as in the training aspect? Over to you.
Thank you so much. So President keeps saying that it is no more a money bank, it is a knowledge bank. So World Bank has started to project themselves as a knowledge bank. So and I feel probably there is a huge value addition in that, because we have a privilege at least to have an exposure to different countries, different systems, and that really allows us to at least help the different governments to have that properly in terms of not committing the same mistakes which the other countries have done, right? Equity is a big issue, right? But at the same time, we also need to see that how do we actually address this issue? It's not only in terms of providing the access, but also it is more of a demand side intervention, right? We live in two different worlds. Okay, on one side, even if I have a cold, I prefer going to the specialist, not to the doctor. On the other side, even if I have a major challenge, I go to the quack, right? So how do we try to basically, bring some level of, uniformity, if not uniformity, at least some level of quality of service? And I'll take the cue from what Vikas said, that it's a pride for the midwiferys to serve different organizations or the facilities. I would also say let's try to bring the element of trust. Can we bring that element of trust in terms of how people perceive, midwiferys in terms of taking the service? And again here, the private sector plays a very critical role in terms of how to create the markets. Everyone thought about Practo in order to have a long list of doctors and you can pick and choose, right? Why can't we think of maybe having a Practo for the midwifery? If I'm a pregnant woman, I would like to have a company, a companion who can actually help me through the entire journey. So how do we do that? We inherited predominantly the systems, the entire architect from the England. It's a legacy. And today, if you go and look at the entire health system, it's like nurse-led departments, nurse-led facilities. So where did we really miss upon? Maybe we did not look at the transition. But this also, again, the governments have become pretty proactive nowadays. They started to look at every investment purely from the lens of an economist to see what is the rate of returns I'm getting. And it's probably a very right environment for everyone to think about. Most of the state governments, if you go and talk to the policymakers, close to about 60 to 70% of our the health budgets are going to the salaries, right? The program budget is very limited and it is shrinking day by day. Now, in that environment, is it wise for me to get one specialist or one doctor versus having, say, 5 nurses or midwiferys is something, the state governments have also started thinking about. And the beauty of India is health is a state subject, and the kind of different innovations you people have been doing, like Bihar, such a fertile land, has demonstrated something. Similarly, UP has done quite a lot of work. my own state, like Telangana, AP, they have been doing significant amount of work. But how do we actually translate this into an action? And this action is just not with the government, it is also from the markets, from the people. Right? And it is quite evident, and I'm sure you people will agree with me, that most of the high impact interventions do get translated from the private sector or from other countries, and then it becomes a public health program element, right? And if you really want to do that, then the point is how do you demonstrate it? Can you demonstrate that, okay, fine, if midwifery-led facilities are really showing results, it's not only good in terms of the quality, but it is also accepted well. Then obviously the government will be, will have a strong case. Will have a very strong case in terms of adopting those changes which are people-led. It is more accepted. So I think there is an approach which one can take. We probably don't have the challenge in terms of shortage of people, shortage of skills, right? In the other countries, which is, in African countries, you go and see that the facilities are led by the midwiferys, or even in the developed countries, there is a huge shortage. But they also learn the whole art of economics putting into the larger public health system. So I think we are there. Probably it's a last leg for all of us to really push hard and see how we actually bring that whole element of trust along with the pride in order to make ourselves more relevant to the system.
I think you are pointing out that somewhere the public awareness campaign also can be a part of this initiative which is there in midwifery model of care implementation in our health system. I think people don't know because it is so patchy, so small places, and I think that is a good point. I think we should work towards it at all level in all the states where we are implementing this. Dino, I would like to ask you, what is the process did you follow that you are becoming a successful state in implementing this midwifery model of care implementation and health system in Bihar? So how did you go about, and how did this national guideline help you?
Yeah, so as earlier said, as earlier said, State Midwifery Task Force has a great role in this, because without that core committees, we can't do anything. So it is awareness and sensitization meeting of State Midwifery Task Force at the state level. Saying we had district midwifery action group at the district level. So we have initiated from Patna, and now we have MLCUs at Begusarai and Gaya also in streamlining. So this batch after training they will be deployed in Gaya. So we already constituted district midwifery action group in 3 districts. So likewise we have institutional core committees in SMTIs as well as these MLCUs. So the thing is, we all know that this is a new program, so we have so many confusions and troubles, and some of the collaborative care, we need all the support from all healthcare personnel, including specialist doctors, and coming to ASHAs, ANMs, staff nurses, all we have to. So for that, for sensitizing them also, we had meetings at each and every level. So smoothening of the implementation of this program as guidelines already helped a lot. Along with that, some of the state specific matter as well. For example, we need a cadre rule. Without cadre rule, I don't think it will be sustained. So I think for cadre rule, if it is good, because in guidelines also they have given a cadre rule, but I request Ministry of Health if we give more clarity in the cadre rule so that the states can follow that, and strictly this will be implemented in each and every state. So this program will be sustained. Yeah, thanks.
Thank you, Jenu. And with this, I think we are coming to end of the panel. I just request Madam Usha to sum up and.
Thank you, all the panelists. So well, this very important topic has been discussed by all of you. We got a lot of input, and few things that I just took. One very important thing that we should come out with, SOMI can come out with a white paper along with Chicago. Can we make it a combined one? And prepare a white paper where we can put our issues. Okay, so that is one thing. Secondly, sir said people driven. We need to create demand for midwives by the people. People have become so used to depending on doctors for normal, natural, physiological births. So this trend, which is being followed for such a long time, needs to be little changed, and demand needs to be created. This right now I can't discuss. I will be discussing with them later on how when we started, how it came from the mothers. We want this. If it comes from them, it really works. So that may take time, but this needs to be done. And as Madam said, we need to have competency-based education, starting there, side by side. Even the curriculum needs to be gone through again at every level. I mean, at institutional levels and practice level everywhere. Jinu said that how they were successful in Bihar was there was a collaborative work. They involved all different people from government, from Anganwadi and social district as well as nurses. So that's how it, and they keep on to that. I have that. I told you that they had frequent meetings with people. So that, and you had mentioned, somebody had mentioned that all the NPMEs, educators who have been trained so far, we need to bring them together at one platform and discuss with them how do they feel now, have they any problems, or are they happy, or what change did they find. I mean, like that, if there is if you can bring them all together somewhere, it will be a great a feedback from them. How do they feel now teaching mentoring the NPMs? Private sector should not be forgotten. It's not that only the deliveries are happening in government, and we prepare this particular program which is coming up is for the government nurses. What about private? Nearly, they say 70% of births are taking place through private sector. So only Fernandez is working in a big way. What about others? Can we find some way, somebody create a similar type of program, offer them for the nurses, midwives working in the labor with the maternity, these things, in maternity section for private sector? Can we think of some such thing? So thank you indeed. For me, it has been quite a educative program. Thank you, everybody. Thank you.
Thank you. With this.
It's a flamboyant panel, and I think we have come so far.
Quickly,
Yes.
Sure. Yeah. Thank you very much for that permission. I think we've traveled from different parts. We've come from Hyderabad. We need to take this time to talk, because otherwise it takes us to travel.
But now we have to see when we demanding for midwifery cadre, we will see that whether there are any other areas where midwives can work, or they are having scope of working or creating more opportunities can be incorporated in the midwifery care. And this is the concept of Madam Prakashamma, that whether there can be any research work on this aspect, so that the main points can be incorporated, or can have a research paper, so that there will be some valuable points may come out that we can add into the midwifery services. Okay, so we are having our team who will give their views. So I will request them to give their introduction.
My name is Saira Banu from Take this mic, no Sarah. Only one mic. Start from
नमस्ते, मेरा नाम है अनिता देवी from Assam.
Very good.
Good afternoon, everybody. I am Chaya De, nurse practitioner in India, in Mediapari from West Bengal.
My name is Susila Yadav. I belong to Rajasthan and I am NP. I am Harti Gogoi from Liaison Oil Medical. I am working as a staff nurse in maternity and NICU care.
Thank you, dear.
Good afternoon, everyone. My name is Florina Nisamba. I'm from Meghalaya. I'm working as a staff nurse in District Maternity and Child Hospital, Chura.
Chura is very far from.
So from different states, we are having different participants.
No, they both. No, Sarah and another
Puducherry.
Once more, Sarah, introduce yourself, Sarah, and another one is there.
We started from Anita.
My name is Jacqueline Araki Selvi from Puducherry.
What is your designation?
Working in primary health center for ANM.
Oh, very good. Very good. Sarah, please introduce yourself.
My name is Saira Manu from Pondicherry, LHU from SOMI long member. I am president and also Puducherry chapter. Okay, I am working in primary health center. I am now in the delivery is conducting now in date. Thank you. Shaida Babu, she has voluntarily participated and yes, she has shown interest. So that's why she has been included and she is working as an LHB. So that's why we have included her also.
Very good.
I'm sorry, I'm working from 32 years.
Okay. Now we are having the first questions. What is midwifery practice or what kind of activities can be included in midwifery scopes or midwives as a scope? So I can ask this first question on this aspect. We are having prenatal care, intranatal care and postnatal care in the midwifery aspect. And beyond that, what all scope we are having so that which can be incorporated in the midwifery services. So here it is already there. That's why I am asking that whether they agree or what is their opinion that pre-pregnancy care counseling, including delaying first pregnancy, spacing methods, etc., which are already there. Do you agree that the midwifery scope, what all scopes are there in that areas? Sarika?
Yes or no, you tell. Yes or no?
Yes or no?
Yes. Yes.
You everybody tell yes or no.
Yes.
Otherwise it will take long time.
Yes.
No?
Yes, if you want a safe mother, a midwifery is very essential in this area.
Now, there is our great scope. Okay. And Jacqueline, what is your opinion?
Yes, ma'am.
Yes.
This side, left side.
Yes, ma'am. Yes, ma'am.
Yeah, we are following all this closely in Meghalaya.
Okay.
Then the second one is adolescent girls health and nutrition. Adolescent girls health and nutrition. Whether we are having start from her.
Yes, ma'am. Developers और जैसे health hygiene में lack of knowledge रहता है और बहुत सारी
Yes or no?
चीजें होती हैं
Just tell us no. Yes or no?
Yes, sir. Yes, sir.
Yes, it is also kind of.
In Meghalaya also we are following this one for adolescent
adolescents, then yeah, yes. Yes, ma'am. Yes.
I am also snake, yes.
Yes, ma'am.
Okay. Any from the audience, any
remarks? No बोलता है. We also agree.
Whether all agree?
I am agreeing in this.
Yes.
I not agree because midwives are totally related with the labor progress and
No.
feel what they are doing because adolescent girls health and nutrition are under RKSK is governed by CHO. So midwifery is not involved in my state.
Okay.
That's why another.
Okay.
That is my own opinion.
Because adolescent health is very much affected.
But in my state, madam, it is under RKSK, Rashtriya Kishore Swasth Karyakram, so it is under CHO is doing this work.
Please tell your state.
Okay.
What is this important for midwife? In Rajasthan, Sapna Soni will go to Rajasthan. She will tell the government adolescent health is important for midwifery.
Yes, I will agree because actually this is the time when you prepare the adolescent girl for the pregnancy
Yes, for future mother.
future mother. So
Yes.
there is a need for preparation. So the midwives is the actual real trained or counselor for the adolescent girl. So it can be.
They need very much counseling.
They need counseling. Midwives can do the counseling for the adolescent girl. It could not be separate from adolescent because it is life cycle approach. We started from the adolescent, then pregnancy, then delivery, then postnatal, afterwards newborn, and it is continuum of care.
Okay.
What I'm trying to tell that under RKSK we have adolescent friendly health clinics and these clinics are run by community health officers only. I know that this is not practicing midwifery. Midwives should be do this adolescent health, girls and health nutrition, but in my state this is under RKSK, so community health officers are doing this.
They are doing okay. We are finding the scope of midwives. So